Imagine you're in the emergency department when a patient suddenly collapses, no pulse, no breath, every second counts. Over 350,000 cardiac arrests occur out of hospital every year in the United States. Means one person facing death in every 90 seconds, just for cardiovascular problems. So probably words cannot explain how much it is vital for nurses, doctors, and paramedics to face such a breathtaking condition to save someone's life when every second matters. Advanced Cardiac Life Support, or ACLS, is a compendium of clinical guidelines for urgent and emergent management of cardiac arrest and other life-threatening cardiovascular events by using advanced procedures and medications. The first step of this journey begins by initial assessment of the patient by shaking and shouting to assess any response. "Hey buddy, are you alright?" If there is no response, then quickly we should call for help and activate the advanced life support team and start CPR. For this, the patient must be placed on a firm place, and normally the hospital bed is the best place for this. Then we need to kneel beside the chest. Heel one of the hand on the center of the chest at the lower half of the sternum, and place the other hand on top and interlock fingers. The compression rate must be 100 to 120 per minute. The depth of any compression should be 2 inches to 2.4 inches, but not more than that. This is just for adults. The way of CPR is different for children, that we are gonna explain in another video. Then we allow the chest to fully recoil between compressions. Keep in the mind that the CPR should not be paused for more than 10 seconds. Now it is time to ventilate with a 30:2 compression to breath ratio until the advanced airway is placed. Means delivering 30 chest compressions with no interruption, then 2 breaths that produces visible chest rise. After 2 breaths, immediately restart compressions to have another cycle of 30:2. This process must be continued until the tracheal tube is placed, but the compression should be continued in every step. Oxygen should be administered to keep the oxygen saturation more than 93%. For this purpose, we use BVM or bag valve mask with 100% oxygen. Ventilation should be done at the rate of 10 to 12 breaths per minute, means 1 breath in every 5 to 6 seconds to achieve end-tidal CO2 at 35 to 40, if it's possible. This technique needs 2 persons. One seals the mask and the other one squeezes the bag. Then another member of support team now should attach the monitor and get the defibrillator ready. Now the doctor should check the heart rhythm to know if the heart rhythm is shockable or non-shockable. Shockable rhythms are pulseless ventricular tachycardia or PVT or ventricular fibrillation or VF. Ventricular tachycardia is a rapid heart rhythm that originates from the ventricles and is characterized by a rate more than 100 BPM. Typically between 150 to 250. As you can see in this picture, there are wide QRS complexes like each other with no P wave. This is because of abnormal electrical activity of the heart. And in the next picture, you see an example of ventricular fibrillation or VF. Like VD, QRS complexes here are wide as well with no P wave, but the shape of QRS are completely irregular and chaotic. At the other side, non-shockable rhythms are asystole or pulseless electrical activity or PEA. Asystole means complete absence of detectable electrical and mechanical cardiac activity, like what you see in the movies when the hospital monitor shows a flat line and a monotonous sound. In pulseless electrical activity or PEA, you can see an organized ECG just like a normal ECG. But the clinical condition of the patient has no difference with asystole. The patient has no palpable pulse or mechanical contraction. The approach for any of these rhythms are different, so it's really crucial to know and differentiate them based on electrocardiogram. If the rhythm is either one of the shockable ones, without losing any time, immediate defibrillation should be done by giving a biphasic shock, typically 120 to 200 joules. For using the AED, attach the pads to breeches, not over-medication pads, and make sure cables are connected. Place one pad on upper right side of the chest and the other on chest a few inches below the left armpit. Actually, the AED is not to restart the heart, it restarts all electrical conduction of the heart to stop all lethal arrhythmias. Then we need to continue CPR immediately for 2 minutes after the shock without checking the rhythm. After 2 minutes, now it is time to get an intravenous line. If it was not successful to access IV line after 2 tries, we should go straight to get intraosseous or IO line while the ongoing CPR is still running. After the first shock in shockable rhythm, the CPR should be continued for 2 minutes non-stop, then reanalyzing the heart rhythm once again to know if it's still shockable or not, or there is any sign of ROSC or return of spontaneous circulation. If there is ROSC, we will act based on post-cardiac arrest approach. If it is non-shockable, we jump straight to the non-shockable approach to continue the CPR that we will talk about later in this video. But if it's shockable still, second shock should be given soon. Now here at this point, we want to give the first dose of epinephrine. The dose that has been confirmed as the most proper dose is 1 mg IV push followed by 10 to 20 mg of IV fluid. Then we repeat the epinephrine dose every 3 to 5 minutes. Now we have to repeat a cycle soon by chest compression and oxygenation for 2 minutes again. After 2 minutes, if the rhythm is still shockable, the second shock should be given. We need to know that there is no limit to the number of biphasic shocks that we can deliver during CPR. We continue delivering shocks as long as the patient remains in a shockable rhythms, means a VF or pulseless VT. Then the next medication we are gonna give in this step, mean after the second shock and at the beginning of third cycle, is Amiodarone with the dose of 300 mg IV push. In the next cycle, if the rhythm remains shockable after the third shock, the next dose of Amiodarone will be given at the dose of 150 mg IV push. After 3 cycles of giving shock to the patient, if there is no sign of ROSC and the rhythm is still shockable, we return back to the first cycle where we give epinephrine after every 3 to 5 minutes of CPR. And we keep on performing this cycle until the rhythm changes or the code ends based on the protocol. Now let's go back to the first cycle where we analyze the cardiac rhythm. If after 2 minutes of CPR and checking the rhythm for the first time, if you saw asystole or pulseless electrical activity or PEA, it means we are not allowed to use defibrillator. So there are some change now in the way of resuscitation. In non-shockable rhythm, after 2 minutes of chest compression and breath, we go straight to give an IV line or IO line to give the first dose of epinephrine with no use of AED. Actually, all steps here in the first cycle is like the shockable rhythm, and the only difference here is that we do not use AED because it's completely useless. The dose of epinephrine is just like the same in shockable rhythm, 1 mg IV push every 3 to 5 minutes, and end-tidal CO2 should be checked in every cycle. Every 2 minutes we recheck the rhythm too. If the rhythm changes to shockable in any cycle, we jump back straight to shockable approach and we deliver the first shock to the patient as it's been said. But if the rhythm remains non-shockable, we immediately resume CPR. While we are managing a CPR process, we should consider all reversible causes of cardiac arrest as well. There are about 10 reversible causes that you can see here in this table. We should check whether the patient has any of these causes or not. After doing all interventions and high quality CPR, if still there is no sign of ROSC after 20 to 30 minutes, or no untreated reversible causes identified, or end-tidal CO2 is still below 10, we can terminate the CPR and call deceased. If you are working as a member of CPR team, consider saving this video as a quick review and also subscribe to this channel and hit the bell button to stay notified about other related ICU and emergency topics.